Namaste everyone. Today we are going to talk about croup. Croup is also known as laryngotracheobronchitis. Okay, so croup, we also call it as laryngobronchitis. So, but before we go to talk about group, I think we need to talk about what is it and the pathophysiology. So I'll be focusing more on pathophysiology because we know the pathophysiology, we can what tell what are the diagnosis, what are the management aspects very easily. So when you know the basics, it's quite easy to undergo. It's quite easy to understand everything. So I'll be focusing this class on more about pathophysiology, and it will be way easier to learn about the symptoms, signs, management, and everything. So, croup is an infectious upper airway condition which is characterized by severe inflammation. As we know that the most common cause of this croup is parainfluenza virus 1 to 3, and because it accounts for more than 70% of cases of croup. So if there's an MCQ and if it asks you what is the most common cause, then we have to say it's parainfluenza. It's 1 to 3. If the MCQ is asked such way, then it's type 1. Type 1 is the most common cause of croup. So the other causes of croup can include respiratory syncytial virus, which accounts for almost, we don't have the percentage, but it's the second most common cause of croup. The other viruses that are included in causing croup are influenza, there's A and B, there's adenovirus, metapneumovirus, and so on. So before we go on to talk about the details, I will talk about the pathophysiology. So pathophysiology. So as we know that what is the anatomical structure that is affected during croup. So basically, I will draw one diagram. So this is a diagram of a. This is the larynx. Okay. So as we know that by its name itself, laryngotracheobronchitis, because there's a inflammation around the larynx. So this is the vocal cord. This is the vocal cord, which is a part of larynx. These are the arytenoids. This is the subglottic space. Suppose this is the normal picture of our larynx. So what happens in croup is there will be swollen arytenoids. So these are the arytenoids, which are now what is happening is they're swelling because of intense inflammation. There's a swelling, so there will be redness around the vocal cord. The arytenoids are swollen. Now, suppose this is the normal subglottic space. Subglottic, okay. Larynx is divided into supraglottic. Okay, supraglottic, glottic, and subglottic space. Okay, subglottic space is I think this is the most narrowest part of the larynx. So when this is the normal subglottic space, so it's not narrowed. Now what happens in croup is that the arytenoids get swollen and also the subglottic space is narrowed. It's quite small as compared to this big subglottic space. So we can see is and there's a narrowing of subglottic space. As we know in the diagram of larynx, we know that this is a cricoid cartilage. These are the tracheal rings. The tracheal rings are C-shaped. These are horseshoe-shaped. So shaped, and they are partial. Okay, these are partial rings. Okay, but These we know that this is a cricoid cartilage. Cricoid cartilage is it's a full ring. It's a full ring as compared to these are features of tracheal cartilage. So we know that these are the anatomic landmarks. Vocal cord are present around this. Now suppose there is an inflammation around the larynx. Larynx को वरिपरि इन्फ्लेमेसन भयो भने के हुन्छ भन्दाखेरि यसै त यो स्पेस न्यारोड छ, त्यसमाथि क्रिकोइड कार्टिलेज इज अ फुल रिङ कार्टिलेज. सो यसको चाहिँ इट क्यानट जस्ट डिस्टेन्ड हुन्छ, डिस्टेन्ड गर्न सकेन क्या. इट क्यानट जस्ट बिकम बिगर वान. इट बिकम्स न्यारो स्पेसमा इफ देयर इज अ इन्टेन्स इन्फ्लेमेसन, देयर इज अ एक्जुटेट्सहरू भयो होइन, सबै रातो रातो भयो भने due to its full ring structure of the cricoid, the subglottic space becomes even more narrowed when there's intense inflammation. त्यसपछि के हुन्छ ग्रुपमा जब यो इन्फ्लेमेसन भयो नि, यो एरियामा इन्फ्लेमेसन भएपछि obviously the baby, the child will have difficulty in taking a deep breath into the lungs. Lungsमा चाहिँ air entry चाहिँ it will be decreased lung air entry. जब there is decreased air entry and there is the air is flowing through a narrowed space बाट when there is हावाहरू narrowed space बाट गयो भने will create a particular inspiratory sound निस्किन्छ, which is also known as stridor. Obviously when the child creates, जब उसले आवाज निकाल्छ यो सानो स्पेसबाट आवाज निकाल्यो भने there will be hoarseness हुन्छ, घ्यार hoarseness of voice हुन्छ. And obviously when there is decreased air entry, the child will have respiratory difficulty होइन, respiratory distress को signs हरू हुन्छ. And since these airways are present above the sternal area होइन, sternal area भन्दा माथि भएको हिसाबले र जब बच्चाले चाहिँ के गर्छ भन्दाखेरि कोसिस गर्छ नि सास फेर्न गाह्रो हुन्छ भने they will have suprasternal retractions पनि देखिन्छ होइन. सबकोस्टल इन्टरकोस्टल रिट्र्याक्सन त अरू डिस्ट्रेसहरूमा देखिन्छ, तर सिन्स दिस स्ट्रक्चर्स इज अबोभ द स्टर्नल एरिया र उसले चाहिँ सास फेर्न कोसिस गर्छ, वी क्यान सी देयर इज अ सुप्रास्टर्नल रिट्र्याक्सन्सहरू देखिन्छ. द्याट्स वाइ हाम्रो मेन एम के हुन्छ भन्दाखेरि यो ग्रुपमा चाहिँ वी हेभ टु रिड्युस द इन्फ्लेमेसन, डिक्रिज द इन्फ्लेमेसन अराउन्ड द ल्यारिन्जियल एरियामा चाहिँ इन्फ्लेमेसन कम गर्ने बित्तिकै when the space gets bigger, subglottic space जब इन्फ्लेमेसन कम भयो भने it will not get narrowed अनि त्यसपछि बल्ल उसको डिस्ट्रेसहरू कम हुन्छ. That's all about the use of adrenaline and steroid in Croup. त्यसले के हुन्छ यो एरिया भएको इन्फ्लेमेसनलाई चाहिँ कम गराउँछ. So let's talk about in detail everything about Croup. यो कुराहरु त मैले भनिसके. So we have to very importantly know that parainfluenza virus is the most common cause of Croup, and if someone asks us which is the most common, 1 2 3 भन्यो भने give the answer as type 1. So what is the presentation? As I already said, के हुन्छ भन्दाखेरि there will be a sudden onset हुन्छ कि sudden onset of barking का ग्वाङ 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 त्यस्तो खालको खोकी चाहिँहरू भएर चाहिँ प्रेजेन्ट हुन्छ यो ग्रुपमा चाहिँ. एन्ड त्यो सिम्पटम्सहरू आउनु अगाडि 1-3 दिन अगाडि, सो देयर विल माइल्ड युआरटिआई को फिचर्स हुन्छ, कोरिया चाहिँ नाकबाट सिगान आउने होइन, हाँच्योहरू आउने, मन्दा खालको ज्वरो आउने. दिज आर अल युआरआई सिम्पटम्स. एन्ड एज आई सेड, एज द चाइल्ड इज ट्राइङ टु ब्रिथ against a closed glottis, it will produce a peculiar sound which is also known as inspiratory stridor. Stridor is not expiratory. Okay, expiratory sound ma chai we have to call it a wheezing, but inspiratory आवाज भनेको चाहिँ stridor हो. Obviously the voice will also be hoarse type, that there will be a change in the quality of the voice, and which is known as a hoarse voice. So the child will have difficulty in breathing lying down position, like difficult हुन्छ के अनि त्यसपछि किन गाह्रो हुन्छ भन्दा obviously त्यो closed एकदम narrowed glottis को सँगसँगै lie down गर्दा it will be even narrow, त्यसले गर्दाखेरि the child may show signs of hypoxia, जस्तै there will be peripheral cyanosis and use of accessory muscles which can include scalene muscles, abdominal muscles, intercostal muscles हरू हुन्छ. We can see the use of the accessory muscles, त्यसमा suprasternal retractions हरू पनि we see commonly. So the highest incidence is present between 6 months to 3 years of age. So this is the highest incidence, and a typical history के हुन्छ भन्दाखेरि it usually is more common during autumn and winter months. So भनेको यो दशैंतिरको जब वेदर सुरु हुन्छ and as a winter months मा चाहिँ we see highest presentation of croup. And typical history के हुन्छ भन्दा emergency department मा ED मा चाहिँ the child usually presents with respiratory distress, usually at night. रातिको 10 देखि बिहानको 6 बजेसम्म the most common visits of children with croup come during that time. So history मा तपाईलाई कुनै clinical vignette छ, a child comes at night, 2 years old baby comes at night with a changed voice, with inspiratory noise along with mild fever and a running nose, and has got a typical sudden Barton cough. That is the answer is already croup. So what is the difference? So in the differential diagnosis of croup, Stridor diagnosis we have to consider it's an important clinical feature. Of Stridor we have to see whether the child is a febrile or afebrile. So if the child is febrile, we have to say there's some kind of inflammation. So it can be divided into low grade and high grade febrile. Because low grade usually is a croup मा हुन्छ, usually viral infections मा चाहिँ low grade fever हुन्छ. भन्दाखेरि diphtheria मा पनि there will be low grade fever, and the child might have stridor. But however, if the child is having high grade fever, we have to absolutely think about epiglottitis. It's an intense inflammation of epiglottis. Yes, there is inflammation of trachea. If there's a bacterial superimposition, we have to consider bacterial tracheitis and retropharyngeal abscess are source. But if the child is afebrile and the child is having stridor, foreign body, hypocalcemia, angioedema, or neurogenic stridor, we have to consider as a differentials. So now we talk about the diagnosis ma. How can we make a typical diagnosis of croup? Croup ma chai, the more or less, as I said, it's all about clinical features. Or we just make a diagnosis of croup using the clinical features. However, and the lab is quite non-specific for croup, usually viral infections. However, if we do a lab, it will help to differentiate various differentials. Okay, if there's high WBC count and the CRP is positive, and it includes the bacterial etiological stridor, which includes bacterial tracheitis, epiglottitis, tonsillar abscess, or retropharyngeal abscess, because these are conditions in which the patients are really toxic. Usually patients are toxic, and they are there is bacterial superimposition. We need to provide immediate management in these cases. So there's a very particular sign in chest x-ray that we see in croup. It is also known as stipple sign. I'll show it. This is the sign of stipple sign. It's like a narrowed thing. Narrowed. Again the ear space gets open. Okay, see, this is the charge stipple sign. It's like this. Okay, it's coming like this. Narrowed space line is a broad side, narrowed side. Did you see it? This is known as a stipple sign, charge stipple sign. But we don't have to do chest x-ray in all the cases. Just a differential or lateral x-ray can help in the diagnosis of epiglottitis and retropharyngeal abscess and severity. In our clinical practice, we use a Wesley Croup severity score to categorize the severity of croup. So we can divide it into mild to moderate, severe, or life-threatening. Life-threatening is the one in which the patient is in a very critical condition and the patient needs to be in the ICU, might need ventilation at any moment. It really needs ICU care for severe and life-threatening cases. Whereas mild to moderate cases can be observed in emergency for 4 to 6 hours and can be planned for discharge. However, if we see there's a signs of severe signs, we need to hospitalize and we need to keep the child in ICU if the life-threatening signs are present. For example, we divide this clinical features into these sensorium, distress, stridor, heart rate, and SpO2. For example, if the sensorium is the child is very alert, we can say the child is having mild to moderate kind of distress. Severe, if the child is lethargic but arousable. Whereas if the child is agitated, pain responsive, or unresponsive, but we have to say there's a life-threatening sign is present. If there's no respiratory stress, the child is having mild to moderate croup, and whereas if there's intercostal retractions, subcostal, or retractions are present, it's severe signs. Whereas if there's a sternal, suprasternal, severe or declining intensity without improvement in consciousness, then we can say there's a life-threatening. Suppose a child is having a lot of distress and suddenly there's no signs of retractions. The child might have gone into fatigue. That's a very life-threatening sign. Okay, so we have to be very cautious about that thing. If there is no stridor at rest, the child is having mild to moderate. However, if the stridor is present right at rest, it's severe signs. But if the audible stridor becomes quiet without improvement in consciousness and saturation, then this is a life-threatening. The child is really going into fatigue, that stridor the stridor will just go away and there is no improvement in consciousness, saturation improvement. Well, it's life-threatening, might need ventilation right at the moment. If the heart rate is normal, it's mild to moderate. If the child is tachycardic, it's severe signs. But if the child is having bradycardia, it's a very life-threatening sign. So whereas SpO2, it's more than 95% in mild to moderate and severe. However, in life-threatening, the saturation goes down below 94%. Then we say that the child is having life-threatening signs. So we can also do it through the Wesley Croup severity score. Now we go on to talk about the management. So this is the initial management. Initial management is if the child comes to the emergency department and the child is very agitated, just keep the baby in the mother's lap, because as I already said, if we go on examining the baby, if we irritate the baby, the vocal cord gets even narrowed. Okay, so chances of laryngeal spasm will be there. Laryngeal spasm. So we don't want to create that event. So we just keep the baby in the mother's lap. We just calm the baby. We don't separate the mother from the baby, because separation and crying will worsen the stridor and increase the chances of laryngeal spasm, which is very life-threatening. So we target a saturation of more than 95%. We postpone IV access unless absolutely needed, because it will worsen the laryngeal spasm. We don't insert the trunk depressor, but can be done after stabilization phase. But ideally, it's good we don't do it. We don't sedate the child until the airway is secured, and we don't sift child for chest X-ray before the stabilization. So now we go on to talk about specific management. The specific management is for mild, we can give oral dexamethasone at a dose of 0.3 to 0.6 mg per kg. So as per this is the Indian Academy of Pediatrics guideline of 2022, we don't give more than 8 mg of oral dexamethasone. We can give nebulized budesonide 2 mg. 1 mg BD becomes 2 mg. So that's how we usually manage mild croup. If the child is stable, we keep the child for in the emergency department for 4 to 6 hours. The child has no distress. We can send the child to home and explain the warning signs. If there's a worsening of stridor, if there's poor feeding and decreased consciousness, we ask the parents to bring the child immediately to the emergency. There's no role of antibiotics or beta agonist nebulization in viral croup. As I say, beta agonist is salbutamol. Salbutamol works through beta receptors. Beta receptors are present in the smooth muscles of the bronchioles. It's not the place where there is intense inflammation. So there is no role of beta agonist in nebulizing a viral croup, because the problem is at the level of larynx where there's intense inflammation. So as it is a viral infection, there's no role of antibiotics. However, if there's a moderate to severe signs are present, we hospitalize the children, we nebulize the child with adrenaline nebulization. So what adrenaline nebulization, as I say, this is the vocal cord. There's intense inflammation at the level of the subglottic area. There is congestion. So nebulizing the child with adrenaline will cause vasoconstriction, like the headache. There will be decreased congestion, and it will lead to opening of the lumen. So it will facilitate decrease respiratory distress. That's why adrenaline nebulization is used. We use adrenaline nebulization of 1:1000 diluted 1:1000 adrenaline at a dose of 0.5 ml per kg along with normal saline to make it a total volume of 5 ml. For example, if a child is 8 kilo, we use adrenaline of, so it becomes 4 ml plus 1 ml normal saline can be added to 5 ml total solution can be nebulized. However, if the child is more than 10 kg, it becomes 5 ml. Okay, 5 ml of adrenaline. We can use undiluted adrenaline up to 5 ml without NS. So that's how we do it. If it requires that the child is having still respiratory stress, we can repeat it even after 20-30 minutes, but usually can be repeated after 2 hours if needed. Okay, now if the child is still having moderate to severe distress group, we add steroids, and the steroid choice is dexamethasone. Yeah, we can sometimes use prednisolone, but dexamethasone has been the choice in group. It is indicated in children who recover from adrenaline nebulization, as the effect will wane after 2 hours. The nebulization effect of adrenaline will decrease after 2 hours, but if we need a sustained activity, we add steroids. Steroids decrease the inflammation of this area, because steroids decrease the inflammation of the laryngeal area, and it will reduce the congestion, increase the lumen, and decrease the respiratory stress. So dexamethasone is used variable doses. It can be started from 0.15 to 0.6. So the usual dose 0.3 to 0.6 mg per kg. We give a maximum dose of 8 mg. It can be given by oral, IV, or IM route. If there's no IV access, we can give directly through oral or IM route, and more or less all are equally efficacious. We also can give nebulized budesonide 2 mg in those children. So the majority requires single dose of steroids. However, in severe cases, we can give frequent doses of steroids for the 48 hours. So if a child is going to home from the emergency department, we have to counsel the parents that this viral group will usually settle from 48 to 72 hours, and there's no need to much worried, except for the warning signs, as I already said, which includes increased stridor, decreased feeding, and decreased level of consciousness. Otherwise, since it is a viral infection, the viral infections, we have to more or less manage it supportively, which includes, yes, hydration is the most important thing. It has to give adequate amount of fluid, and if there's antibiotics can be given if the child is having fever, and we can give nasal saline, nasal drops like normal saline can be given to reduce the nose blockage. Nose blockage को लागि हामी चाहिँ nasal dropsहरू दिन सक्छौँ. This is all about the management of croup. Thank you very much.